I would like to welcome everybody to Ljubljana. I'm living in this city. I was born in this city, and I'm so happy that all of you had a chance to see it. Um, Thank you to CSO with this global meeting that brought to Ljubljana, and I hope you enjoyed it. Now, I will today talk about electrophysiology. It's quite the other part of the spectrum that we were listening today. And I would just like to say a few words about our eye hospital in Ljubljana, which was established in 1890. And it was like a building that was too old to be reconstructed, so it was destructed. And in 2000, we moved to a new hospital. And here is the portal of the remaining of the old hospital. We left it as a token to history of 134 years this year. We are also quite proud on our new center for rehabilitation of visually impaired, which has been opened just last year, and is really giving full spectrum of rehabilitation to our visually impaired patients. Now, to go back to the topic, to electrophysiology, we will be talking about different responses from the retina and from the optic nerve and visual cortex. And if you remember this from your residency training, I believe, you have a number of responses that are created in the retina. And this is actually, how to say, layer by layer diagnostics. So if you want to have information about photoreceptors, you will have cone and rod responses, and then have mixed responses, and then 30 Hertz flicker, which only cones can follow, and then pattern EIG, which will give you the information of ganglion cell layer, and then multifocal EIG, which will give you topographical function of the retina, and visual evoked potentials, which will give you the information whether or not the signal from the retina reached the brain and how fast this signal travels to the brain. And that's all been standardized. Now, this has been an old photograph, probably that scared most of you to ever use electrophysiology, but now this has been really changed with new electrodes, and one of those were described by ourselves in 1992 that are just simple, like a hook, like a wire that you can just hook it and leave it there for a while. It has 3 contact windows here on the insulation, and children can tolerate out of 6 years onwards. And what you can get then are these 5 responses, which are standardized by ICEF. So dark adapted full retinal response or maximal response, and then dark adapted rod response. So if you leave somebody in the dark for 20 minutes and then have a dim light, and then you get this slow rod response coming up. Oscillatory potentials that are responses from endocrine cells, and then if you leave somebody in the bright light and then shine even brighter light, then you get cone response because you filter out the rods, okay? And retina responds only to, only cones respond to flicker, which is a 30 Hertz, so fast responses. So we have in, for example, optic media problem. If you are interested if macula works or not, just 31st flicker will tell you that. Okay, now pattern EIG, again, as I mentioned before, is a checkerboard pattern evoked stimulus, and this checkerboard pattern changes darkened white squares. So it's actually a stimulus which is tailored to on and off system in the brain, which actually also exists in ganglion cells. So ganglion cell response will be the one that is here, the negative response N95. And that's quite useful to have this for diagnosing selective ganglion cell disease or optic nerve disease, which actually retrogradely degenerated ganglion cell layer. And then VEP, as I said, when the signal travels to the brain, takes about 100 milliseconds. And if this is delayed, then we think about whether or not this is due to retinal input problem or optic nerve disease. And that's sometimes tricky differential diagnosis. What is multifocal EIG? This is a reconstruction of the central part of the retina based on the stimuli that differentially stimulate different parts of the central retina, and then computer will reconstruct this image, which will then give you topographical function of the retina. And what is nice about it is that it is not affected by the optic nerve problem. So if you have, for example, blind eye due to optic nerve transaction or whatever, you will still have normal multifocal ERG provided that the fixation was correct, which is very good for differential diagnosis. So you can know, is it macular or optic nerve based on the multifocal ERG. So flash responses are mass responses. So you get the overall general information about the function of the system of cones and rods, okay? But macula is so small that you cannot really say if somebody has maculopathy. You can still have normal cone responses. So that's why you need either pattern ERG or multifocal ERG to show you this. And it is now today a lot of questions whether or not why using electrophysiology, because we have such a nice OCTs and everything can be seen. However, you know, if you have a child, a small child, this is not possible. And if function is really just maybe functional or organic, you can't really say without electrophysiology. And also early changes with retinal dystrophies, they develop usually later. First, the function goes down, and then you see the changes. So you can precede or actually preview the changes that will happen in the retina. And also, as I said, is it due to retina or optic nerve? Is it progressive or stationary? Or is there any objective improvement, especially for clinical studies which are coming up now? Hopefully, with gene therapy, we will be able also to treat these genetic diseases, not only observe them. So I showed you before for the children, for example, if they have, for example, nystagmus, and you don't know whether or not this nystagmus is organic, is it connected to retinal disease, or is it just idiopathic? Electrophysiology will tell you. And you see this child actually has no responses on either eye, so he has labor congenital amaurosis. For children, we use this kind of skin electrodes, which are easy to tolerate. And then medically unexplained visual loss, that's quite often, actually, patients come in with some complaints, you know, with some whatever, you know, complaints that they don't see well, or they see some shimmering lights, or they see some snow, or they see some constriction or fields, and so on. I mean, you need electrophysiology to actually diagnose that. And according to the studies, these are usually female patients, bilateral. 80% have contractive visual loss usually. About 60% complain of glare and pain, and xeroscotoma is very rare, and very few actually turn out to be organic. But then, if you don't have electrophysiology, you can't really rule out that it is organic. And for example, this was a lady that has 1.0 central vision acuity in both eyes and had normal color vision, but she had symmetric constricted visual fields, although OCT was normal. And she said, I was operated for ovary carcinoma a couple of weeks ago, and I see shimmering lights. And what would you do? I mean, you know, so you do electrophysiology. And what it shows is that she actually has no dark adapted ERG there. And what she has actually is paraneoplastic retinopathy in early stage. So you should believe this ladies sometimes, even if they don't look very suggestive in a way. So that's another case. 61 years old gentleman, and not only women, who has concentric visual field loss, claims 0.4 vision both eyes in 61-year-old gentleman with normal fundus. OCT was perfectly normal. And what he had is, you see, again, rod responses are missing. B wave is reduced, and you have this kind of response here, which is telling you that on bipolars are not working. And that's typical picture which you see in congenital stationary night blindness in children, but if it's acquired, the only diagnosis is melanoma associated retinopathy. And this gentleman actually had a skin melanoma that actually started to develop and cause this retinopathy, which was purely functional. Okay, and then if you have maculopathies, macular dystrophies, in the beginning you may not see anything, you need electrophysiology. And for example, this patient here shows abnormalities only in the multifocal ERG. Why? Because the population of the cones in the region around macula is still large enough, actually, not to see anything on full field responses, on flash responses. So you need multifocal ERG to show you this. And then if you have toxic maculopathy caused by chloroquine, for example, you will see this reduced responses around the macula here. And this is what we usually call this kind of, a flying saucer sign in the toxic maculopathy caused by chloroquine. That's another case which is, from a little bit another spectrum. And she had 0.1 vision, again, a lady of 37. And color vision was down to 1/11, and her vision was, her fields were normal. An octopus with 30 degrees were normal. And only when you did macular program, you would start to see some scotoma. So would you believe her that she has 0.1 vision, no color vision? Everything normal, OCT normal? Yes or no? With this kind of visual field effect? Very, very small, even very little here. Okay, she did have a couple of lesions in the brain that could be associated with MS, with multiple sclerosis, but what you find here is that macula is perfectly normal, in contrast to the ones that I showed you before. However, she has loss of N95 and very delayed and reduced P100 of EP. So what did she have? She had symmetrical optic neuropathy due to multiple sclerosis, which sometimes, very rarely, go symmetrically in both eyes. So with this kind of chart, you can then discern which part of the optical system is not working and figure out the diagnosis. And it's a bit complicated, so I will not go through it in the interest of time. What I would want just to say is that we are hoping to see with the gene treatment coming up that ERGs will start to rise, not only decrease over time in these diseases. And now in the second part of this talk, because it's a CSO users meeting, I would like to give some attention to the Retimax, which is a machine developed by CSO and Claudio Baglini, who is my dear friend for many years. And this is really a useful machine. And also, you, along with this, if you are a beginner, you get this kind of flow chart for diagnosis based on the symptoms that patient talks about. And it's quite a useful flow chart. And again, it's a bit complicated to go through in this talk, but it's very useful. So Retimax does almost everything, or even everything. So this is a handheld mini guns built, useful for children. Then pattern ERG and VEP can be recorded with the screens with checkerboard pattern, and multifocal ERG with the M sequence pattern. So you can get all in one system. So it's very useful, again, for children, but also with inbuilt cameras, so you see whether the child is following or not. And electrodes that are used with the machine are HK loop electrodes that we described. And what is nice is that if you buy a machine, you already have a normative data in the machine, so you don't need to do your normative data along the age groups, so it's already built in, so you can actually start to use it right away and use the machine as I described before. So this is an example of examination outcome for cone responses. You can see these nice peaks here, and this machine tells you immediately where you are in terms of amplitudes, so you have a quick overview of the function of the retina, of the cone responses, and then This is an outcome for pattern EIG responses, again with the normalized data where you are, and multifocal responses as also here, and the VP. So there's always normative data built in, so you get very quick and reliable information about the function of the optical, of the visual system. What is also nice is that you can actually superimpose images of the function of the retina to the actual anatomy of the retina, so you see which part is working, which part isn't. And you can do this on a color image, or you can do it on Optos image or things like that. So you can actually see the correlation based on the morphology functional results. Also on visual fields, you can do overlap and see whether these are corresponding to the visual field effects. So one thing which is interesting is not only diagnostic apparatus, but it can also be used for treatments, on different types of treatments. And it is a new, let's say, new domain or new paradigm that vision can be trained. We thought maybe, you know, vision is used all the time. It cannot be trained because we use it anyway. But it's interesting that studies have shown that vision actually can be trained, and the study that we performed with this machine, with Vision Trainer, was vision training with VEP biofeedback in children with amblyopia after critical period, and we were interested whether or not with the training these children can see a bit better. And these studies actually show that attention and perception can be learned and actually enhanced. And this perception training is something that can actually change over time plasticity in the brain and actually have better vision in the end. So what we did is that we tested 7 patients, 8 from 8 to 16 years, and did 2 sessions per week for 10 consecutive weeks. And we did 5 by 2 minutes of each session. So the patients needed to be focused as much as possible, and feedback was actually presented in terms of the size of the square and the pitch of the voice that machine produced. And now maybe if you have voice, can you raise voice? Okay, so machine will tell you the higher the voice, the better the fixation. So the patients are trying to fixate as good as possible. And if they fixate really well, there will be this square will become smaller. Okay, so this can be actually used for training. And also what we did is that we also recorded VEPs so that we could see whether there is any objective feedback of this feedback. And actually you can see that if the patient is fixating well, like these 2 patients, what you see is that fixation target size and VEP amplitude would increase, and the patient that did not fixate well and did not actually show poor attention, that was not actually the case. So our results show that amblyopic children after critical period did improve for about, in average, about 2 lines. And actually, what was interesting that this effect was lasting even 1 year after. So if you learn something, you can actually then use it as, I don't know, somebody that goes and picks mushrooms and is very well trained, you know, and you will maybe pick 2, 3 mushrooms, he will have the whole basket. But when you learn, you will also pick, you know, as much as he does, and you will not need to retrain that again. So you will be trained again. And this results actually do show this in a way. So we were actually quite impressed that we could get actually about 2 lines vision of these children who were actually already after critical period. And to end up with this, is this what comes maybe in the future, is that the studies recently showed that retina can actually be reset. However, reset is not a simple one. You have to put in the retina tetrodotoxin, which is one of the most poisonous substances. But then tetrodotoxin, after actually it washes out, starts to work again. The studies showed that amblyopia can be actually alleviated after this reset. So a lot of studies go into interaction of how to reset the retina, and maybe we will have in the future possibility to actually treat amblyopic children after the critical period. So I thank you very much for your attention.